There is a tendency among the students and most of the clinicians to label all cases of polyarthralgia as rheumatoid arthritis. Though there is no dispute about the fact that the most common cause of polyarthritis is rheumatoid, yet not all cases of polyarthritis is rheumatoid. There are a plethora of conditions with this presentation. Rheumatoid and its variants are infamous in creating diagnostic dilemmas. Difficult to diagnose and difficult to treat, it is indeed a problem which presents a nightmarish experience both to the doctor and the patient. We are all familiar with the saying regarding rheumatic fever, it licks the joint but bites the heart. Contrarily, it can be said of rheumatoid arthritis, it bites the joints, licks all other systems of the body and barks at the treating physicians. A chronic scourge which writes the obituary of the joints, especially those of hands and feet. Rheumatoid arthritis is a problem which needs to be understood in toto to successfully combat it and keep it subdued and improve the quality of those unfortunate victims afflicted by this malady. The rheumatic diseases embrace an amazing array of hereditary and acquired disorders with a wide variety of clinical features. As per the present understanding, rheumatic disorders can be classified under three broad headings. The rheumatic diseases embrace an amazing array of hereditary and acquired disorders with a wide variety of features. As per the present understanding, rheumatic dis can be classified under three broad headings. Diffuse systemic rheumatoid arthritis, seronegative spondyloarthritis, systemic lupus erythematosus (SLE), polymyositis, scleroderma. Localized articular osteoarthritis, crystal-induced arthritis, traumatic arthritis. Non-articular fibromyalgia, low back pain, tenosynovitis. Rheumatoid arthritis definition. Rheumatoid arthritis, described in detail for the first time at the end of 18th century, is the most common inflammatory disease of the joints. It is a systemic disease of young and middle-aged adults characterized by proliferative and destructive changes in synovial membrane, periarticular structures, skeletal muscles and perineural sheaths. Eventually joints are destroyed, fibrosed or ankylosed. It is a widespread vasculitis of the small arterioles. Incidence is 3%. Sex 80% affected are women. Male-female ratio is 1:3. Age. No age is exempt, mean age is 40 years. Etiology. The exact cause is unknown, but malfunction of the cellular and humoral arms of the immune system are cited as the probable cause. Current hypothesis: an initiating antigen triggers an aberrant response, which becomes self-perpetuating long after the offending antigen has been cleared. Antigenic agents which probably act as predisposing factors are viruses, rubella, Epstein-Barr, etc. Genetic, common in people with HLA-DR4 60%, psychological stress, allergic factors, endocrine factors and metabolic factors. Pathogenic spectrum Fig. 29.1a. Against unknown exciting antigenic agents, rheumatoid factors are elaborated. Rheumatoid factors are synthesized in rheumatoid synovial tissue and are mainly IgM in 70 to 90% of cases. In the remainder 10 to 30% it could be Ig, IgA or IgA. This rheumatoid factor along with Ig triggers off a complement cascade. The WBCs engulf this immune complex and elaborate lysosomes. Neutrophils release procollagenase, which is converted into an active collagenase by the synovial fluid. This splits the collagen of the articular cartilage. The neutral proteases complete the degradation of the collagen fibrils. Pathology as explained earlier due to the synthesis of autoantibodies. Against unknown antigenic agents in the synovium, primary synovitis sets in. This primary synovitis gives rise to pannus, which in turn forms the villus. This villus migrates towards the joint, causing its destruction and ankylosis, fibrous in the early stages followed by bony ankylosis in the late stages. Clinical features: rheumatoid arthritis usually presents in three forms. Classical presentation in this group patient is usually a woman in her mid-30s. Pain, swelling, stiffness of the small joints of hands and feet are the common presenting complaints. Patient also gives history of weight loss, lethargy and depression. Joint swelling could be symmetrical and the patient presents with deformities of bones and joints in the late stages. The patient gives history of remissions and exacerbation of symptoms with seasonal variations. This is a very classical complaint in the absence of which diagnosis of rheumatoid arthritis should be carefully made. Symptoms fluctuate from day to day. Table 29:1 shows the recent diagnostic criteria for rheumatoid arthritis. Other presentations: this consists of palindromic presentation involving one or two joints, systemic presentation usually seen in middle-aged men presenting with pleurisy, pericarditis, etc. It mimics malignancy. It may present as polymyalgia, particularly in elderly patients. It may present as monoarthritic swelling. Sometimes the presentation may be very explosive, unlike the usual chronic presentation. Extra-articular features: two or more features are present in 75% of the cases. Rheumatoid factor is invariably present and indicates a bad prognosis. Subcutaneous nodules are present in 25% of the cases. It is seen over the elbow, sacrum and occiput. Nodules may also be present in lungs, eye, heart, etc. When present over flex or tendon, it may cause trigger finger. Widespread vasculitis. Blood abnormalities commonly encountered in rheumatoid arthritis are chronic anemia, iron deficiency anemia, vitamin B2 and folate deficiency, leukocytopenia, thrombocytosis and marrow hypoplasia. Osteoporosis could be generalized or localized in bones around the joints. Eye changes seen in rheumatoid arthritis are keratoconjunctivitis sicca or Sjogren's syndrome, episcleritis common, scleritis, serious problem, secondary glaucoma and scleromalacia perforans. Lung affections in rheumatoid arthritis are pleurisy, pleural effusion, Kaplan's syndrome, Ra plus pneumoconiosis involving the upper lobes, and fibrosing alveolitis in 2%. Heart affections in rheumatoid arthritis are pericardial friction 10%, pericardial effusion 30%, arrhythmias and heart block. Neuromuscular system involvement includes carpal tunnel syndrome, mononeuritis multiplex, muscle wasting, subluxation of C1 and C2, etc. Reticuloendothelial system affections include splenomegaly 5%, Feltes syndrome in 1%, Ra plus splenomegaly plus neutropenia, generalized lymphadenopathy and painless pitting edema of the feet and ankles. Rheumatoid arthritis can affect any joint in the body. It involves the peripheral joints more often and very rarely affects the larger joints. Of particular importance are the affection of the temporomandibular joint and atlantoaxial joint, which can prove lethal due to the cord compression. Figure 29.1b shows frequency of involvement of various joints in rheumatoid arthritis. Quick facts: joints involved in rheumatoid arthritis: metacarpophalangeal and interphalangeal joints of the hand and feet, shoulder, elbow and wrists. Hip, knee and ankle. Others temporomandibular joint, atlantoaxial joints and facet joints of the cervical spine. Orthopedic deformities of the hand. Rheumatoid hand. The following are some of the very common deformities seen in the hand. Figs 29.2a to I and 29.3a to C. Symmetrical peripheral joint swelling of metacarpophalangeal and interphalangeal joints. Fig. 29.2a. Ulnar deviation of the hand is due to rupture of the collateral ligaments at the metacarpophalangeal joints, which enable the extensor tendies to slip from the grooves towards the ulnar side. Fig. 39.2b. Boutonniere's deformity is due to the rupture of central extensor expansion of the fingers, resulting in flexion at the pip joint. Swan neck deformity is due to the rupture of the volar plate of the pip joints, which enables the tendons to slip towards the dorsal side. Fig. 29.2c. This is also known as intrinsic plus deformity. Here there is hyperextension of the pip joint and flexion of the dip joints. Figs 29.2a to L. Various orthopedic deformities in rheumatoid arthritis. A. Symmetrical swelling of peripheral joints. B. Ulnar deviation of the fingers. C. Swan neck deformity. D. Swan neck deformity. Thumb and boutonniere deformity of the fingers. E. Subcutaneous nodules over the elbow. F. Rheumatoid knee synovial thickening. G. Rheumatoid knee. Articular cartilage involved, bony ankylosis. H. Rheumatoid foot, hallux valgus with dorsal closer T, and 1 clawing of toes plantar closer T. Trigger fingers and trigger thumb are due to nodules over the tendons. Rheumatoid foot. It affects the forefoot, midfoot and hind foot. In the forefoot, patient may develop hallux valgus deformity of the great toe, claw toes, closity over the dorsum and the sole, widening of the forefoot, etc. The heel may show valgus deformity. Other joints in the knee. Initially there is a gross soft tissue swelling due to synovitis, and in the later stages, the patient may develop fibrous ankylosis or bony ankylosis due to widespread destruction of the articular cartilage by the pannus. Fig 29.2g. Similarly, other major joints of the body like the hip, ankle, shoulder, and elbow could be involved. The rheumatoid knee synovial hypertrophy and effusion, which may become gross flexion and valgus deformity of the knee. Rarely, wind-swept deformity. Valgus one knee, varus of the other. Baker's cyst may be present. Instability of the knee. Secondary OA may develop. The rheumatoid hip involved in over 40% of cases. Pain in the hip. Trochanteric bursitis may develop. X-ray may show protrusio acetabuli feature. Secondary OA may develop. Investigations laboratory HB percentage is low and shows normochromic, hyperchromic anemia. WBCs are decreased or normal, there are increased lymphocytes and the ESR is raised. Serological tests. Basis. Rheumatoid patients' serum contains Ra factor, which in the presence of Y globulin agglutinates certain strains of streptococci sensitized by sheep cells and latex particles. Remember, Ra factor is found in 75% of rheumatoid arthritis cases, 10% in healthy elderly people, 10% in malaria, etc. Radiological features of rheumatoid arthritis: soft tissue swelling, juxta-articular osteoporosis, erosion of joint margins, joint spaces are decreased, deformities, atlantoaxial subluxation, subchondral erosions and cyst formation. Fibrous and bony ankylosis develops in the late stages. Figs 29.4a and b. Other common abnormalities these include increased C-reactive protein (CRP), increased alkaline phosphatase, increased platelets, and decreased serum albumin. Synovial fluid analysis. This is not performed routinely for diagnostic purposes but performed to exclude other causes of inflammation such as infection. Synovial fluid in RA is typically yellow, watery and turbid due to high WBC and has low sugar content. Management aims of treatment: Fig. 29.4c to keep inflammatory process at a minimum, thereby preserving joint motion, maintaining healthy muscles and preventing secondary joint stiffness and deformity. To keep constitutional symptoms at a minimum. The possible deformities are anticipated and prevented by appropriate splinting. Finally, surgical measures to correct the deformities, eliminate pain and provide stability are undertaken. General measures: NSAIDs, surgery. Fig. 29.4c. Treatment triad for rheumatoid arthritis. General measures: it aims at improving the general condition of the patient and to keep the joints properly splinted in functional position to guard against the ensuing ankylosis. Rest in bed. Good diet, rich in proteins and minerals. Transfusion and hematinics to correct the anemia. Hormones: combination of estrogen and androgen to improve the bone stock. Removal of infective foci. Aim of surgery in rheumatoid arthritis is to relieve pain, correct the deformity of the joints, reduce joint instability, improve the range of movements of the joints. Surgical advice should be sought only when the disease is clearly progressive and conservative measures are failing, but before the patient starts to lose a significant amount of bone stock. If surgery is delayed, more bone is lost, the soft tissue deteriorates and the deformity increases. Preoperative considerations before surgery for rheumatoid disease. A number of specific points should be checked. Related conditions such as diabetes, hypertension and anemia should be adequately treated and steroid dosage should be reduced. There should be no active infection. A radiograph of the cervical spine should be obtained to exclude instability. Surgical methods. Table 29.3 Synovectomy. It may be indicated in patients with rheumatoid arthritis if joint destruction is minimal and if the main cause of pain and swelling is synovitis, which is resistant to medication and physiotherapy. Synovectomy is usually carried out over the knee and ankle, in the elbow with radial head excision if necessary. In the wrist, dorsal synovectomy and resection of the distal end of the ulna can prevent attrition and rupture of extensor tendons. Synovectomy has to be virtually complete to avoid regrowth with recurrence of symptoms. Osteotomy. Fig. 29.5b. This should be considered in patients under the age of 60 years with osteoarthritis of the hip or knee due to rheumatoid arthritis. Osteotomy has the advantage of relieving pain without sacrificing the joint surfaces which have only been partially damaged. At the hip, intertrochanteric osteotomy, which contains the femoral head within the acetabulum, is preferred. At the knee, abduction osteotomy is preferred. Arthrodesis of the joint gives excellent long-term pain relief. But the stress may cause secondary OA in the adjacent joints unless they are able to compensate for the loss of movement. Lack of movement after fusion of the wrist can be absorbed at the elbow and shoulder without significant functional impairment, but fusion of the hip puts considerable strain on the spine and the knee. Arthrodesis, therefore, tends to be preserved for peripheral joints, such as the wrist, ankle, and IP joints of the hands and feet where the functional loss is less disabling and arthroplasty is less reliable.